And before I tell you what I'm going to tell you, I need to tell you about my healthcare setting, because it may or may not resonate. So I spread my time between 3 different trusts. I work a day a week in the community covering prisons, walk-in centres, district nurses, school nurses. I spend a day a week in a laboratory trying to spell Moldertoff and remember what they stands for. And then I spend 3 days a week at Chelsea doing ID clinics and OPAC clinics and seeing people with HIV and things like that. And then the medical schools spend some time doing stuff with me. Across those 3 healthcare organisations, there are 11,000 staff at Imperial Trust, 7,000 staff at Chelsea Trust, and 5,000 staff at the Community Trust, a mix of doctors and nurses and lots of healthcare professionals who are all prescribing antibiotics. Not all of them, but many of them. And amongst those 3 organisations, there are 20 of us, 20 people who are either infectionists or infectious diseases or microbiologists. There are 20 out of about 20,000 staff. And then we have a host of specialist pharmacists to help us in that work. So what does that mean? That means that we purport to have a little bit of expertise, and then we try and infiltrate our expertise out to the people who have expertise in other areas, but who are prescribing the drugs which we think we know something about. So how can you do that? How can you diffuse your knowledge out there? Because you can do it through upregulating your laboratory, churning out better results faster. That's a kind of a foundation stone to what we do, right? And we've heard a lot this morning about how to do that. But not all patients grow bacteria. And one of the slides earlier from Tim, I think, said that only 7% of all blood cultures are positive, but that's the kind of ballpark figure. And it changes from urine to blood to sputum to wound swabs, right? But by far and away, the majority of your patients, you're probably not going to achieve a microbiological diagnosis with. So how do you diffuse out your knowledge about which is the optimal antimicrobial, or it's not really optimal, but your best guess antibiotic, to all of those punters for whom you have no guidance from the laboratory? So we all develop antimicrobial prescribing policies for that reason, right? And we've had those since the late 90s, and we've written them down on pieces of paper, and then we got intranets, and then we put them on the intranet, and then people had to log in and scroll down and look up the blood results for Joe Blogs and then look up what the antimicrobial prescribing policy says on the intranet. And there was always an implementation gap around there. Fast forward to now, and every single one of you in the room will have one of these in your hand. And many of you, like Phil here, is at least 3 screening for 2 different iPads and a phone at the same time. So portable information, 4 screening, 5 screening, Phil. So many of us have highly technological bits of kit which can help us make decisions at our fingertips. So for the next 20 minutes or so, we're just going to talk through some of the ways in which we can do that as infection specialists, and then the people who are using it as clinicians can try and get the most out of it. And we're going to think about these decision support systems in 4 main areas. 1, choosing empirical therapy. It's the best guess drug, the best guess dose at time 0. Then we're going to think about how we can use these things to optimize IV to all switch, how we can use them to promote shorter courses, and then that golden nugget, which I will fail to do, it's not a show ruiner, I'm afraid, but I do fail to use decision support systems to diagnose infection. But I'll show you how we're kind of exploring that area. So let's start with optimizing empiric therapy. So I love fingertips. I love fingertips because it is an outright lie. So fingertips tries to purport epidemiological data about antibiotic resistance in using geographical markers. So here for E. coli bacteremias, for example, the fingertips lie is that if you get an E. coli bacteremia in Cornwall, 1 in 10 of them will be resistant to cephalosporins. Is that true? Is that true for Penzance, through to Truro, through to everywhere else? Is it true for an E. coli bacteremia from a hematology-oncology patient who's 6 months into their bone marrow transplant, or for a 23-year-old who walks in through the door? Now, I would argue not. And if you believe fingertips data, and if you believe that 1 in 10 is a homogeneous number that affects everybody in your county, then you're a fool. The second lie is that the Southwest is a nicer place than London.
Is that a lie?
Well, I grew up over the river in Devon, where we put the jam and the cream on the right way round. And that is a lighter colour than Cornwall. But up where I work now, because I'm forced to because of my wife, it's very, very dark purple. So what does that mean? That means we have a lot more antibiotic resistance in London than maybe the southwest, maybe. But it's very human to look at one's neighbours and to covet what they have or to sniff at what they have if you don't like it. So you may sniff at us and say we have a lot of antibiotic resistance. We sniff at the Southern Europeans. The Southern Europeans sniff at the South Asians, and then antibiotic resistance rolls down that kind of curve. But this is the evidence for that first lie. So our fingertips data for London says that our gram-negative resistance to cephalosporins is about 19%. But for our young people coming in from the community with gram-negative resistance, we have about your rate of resistance, about 9% really. But then look at our intensive care and our renal inpatients, up to 1 in every 2 of our gram-negatives we cannot now use cephalosporins for, and read into that, cannot also use augmentin or tazocin. So that's our kind of population. And I think Tom this morning mentioned the fact that actually what we need to do is not have such broad brushstroke policies, but to personalise it for different areas. So based upon this data, which is about 100,000 bugs from about 70,000 patients, we attempted to do that using clinical support systems. And it's not really just all about ESBLs. Now this may or I suspect may not resonate with the southwest, in that this is our carbapenem resistance, and I'm hoping beyond hope that you don't have this level of carbapenem resistance in the southwest yet. So in some of our units, particularly there our renal medicine unit, 1 in 10 of our Klebsiellas are now out of luck. We're having to use colistin. So that is the kind of heterogeneity of resistance we are dealing with in London. And Lord O'Neill got a lot of stick for his modelling data that was used in those Lord O'Neill reports that said by 2050 the whole of the British Isles is going to be turned into skulls. I love that animatronic from this morning. Ramanan Lakshmanarian from Washington did a slightly more evidence-based mathematical model which went out to that kind of 2030 zone. And this is what he's anticipating resistance is going to look like going forward. So not only do we have a lot of heterogeneity resistance, not only is there sneaking resistance to bad bugs, not only is that resistance very hodgepodge between different patient cohorts within the same geographic area, but it's going to get a lot worse. So Martin's group, as part of the ART project, a few years ago now, sent out to 100-odd secondary care facilities, what do you use as your first-line antibiotic prescribing policy to treat these different conditions? And he went through some fairly common things that walk in through the door of every medical take, right? But look at that colour variation there. Look at that heterogeneity amongst the UK. And as Tom said this morning, do we need that heterogeneity? Or do we need more heterogeneity, I would argue. So let's just think about that. So back in the late noughties, or whatever we're calling them now, about 2009, we were some of the first people to realise everybody had mobile phones in your pocket. So we developed an in-house precursor to MicroGuide or RX guidelines, whatever you use. And we did the kind of decision tree stuff that you all have in your antibiotic prescribing policies. So you flick down as a clinician, you say, my patient has community-acquired pneumonia. Click, click, click. They have a penicillin allergy. Click, click, click. They're pregnant. Click, click, click. This is what you give them. Lovely jubbly. We also, because it was developed for iPhone, spit on them, we had spinny wheels for people to think about creatinine clearance and dose adjust for that. And we put that forward, and we put it forward in 2013, in April 2013, and in about June 2013, MicroGuide registered themselves with UK Companies House. And then in the first month of 2014, RX Guideline registered themselves with Companies House. So unfortunately, I'm not a shareholder in either of those two organisations. Now, Phil said, just before one of his 5 screens started ringing, Phil said earlier that the RX guidelines and MicroGuide are probably blunt instruments, and they are, because they are just rule-based. You, as a clinician, need to decide that your patient has pneumonia or pyelonephritis or cellulitis before you can click through on the rule-based system of that app to where you want to go to. So actually, does that help? Does that have an impact, therefore, just turning everything into an app and bringing it into your pocket and reducing that implementation gap? Well, when we systematically reviewed the evidence behind these apps, because these apps are not free. Now, I don't purchase them, usually the pharmacy department purchases them, but we spend several tens of thousands of pounds a year on these things in northwest London. The evidence is that actually they do reduce process measures. So they do reduce antibiotic consumption. And they do that at a patient level and they do that at a unit level. But actually there is very, very low evidence that any of these apps, any of these decision support systems that are rule-based affect patient outcomes. And that's really why we're all here, isn't it? So actually, why is that? If you drill down into it, it's because these apps, these decision support systems, do not personalize antimicrobial choices for the person in front of you. They actually just make you better at meeting your process measures, which you report up to the board and which you get sequined on. So actually the apps that we're developing have perhaps got the wrong objective, and that's why they're not achieving the right outcomes. So we took that back to basics. We basically just wanted to start again. Having been one of the first people to get out their rule-based apps, we're quite happy to say we've got this wrong and we have undershot where we should be. So we went back and we asked 100 clinicians, respirologists, cardiologists, gastroenterologists, acute medics, even surgeons, yes, and even orthopods. And we said, how do you arrive at a decision to prescribe an antibiotic? How do you do that? And actually, if you involve qualitative scientists and sociologists, then you can codify those hours and hours and hours and hours of transcripts into something that makes total sense for most people in the room. And I would argue that we all try and look for some physiological changes, localize or confirm an infection, send off some investigations, work out how bad this infection is, start some treatment, and then when those results come back in, do something to refine those antibiotics. Fairly sensible, right? But we had to codify that for a reason. Now, some of you may be coders yourselves, because it is 2019. Some of you may know coders, and some of you may not even know what a coder is, but still at least play computer games. So coders are the people who put all those things together. And coders cannot function unless you categorize exactly how decisions are made. And if you categorize exactly how decisions are made, then coders can start to develop artificial intelligence decision support systems to help take those rule-based things that we were starting about before, those apps, that microguide, that RX guideline, and turn it into something patient-specific. Now, how do we do that? So in West London, we're lucky enough to be paper-free. Lucky enough to be paper-free. So everything is electronic. All results, all data entry, all radiology, all through into one centralized data repository, which is the black. But if you actually descend upon that black system, your own bespoke red system developed by the coders that steals all that data in a governance approved way, then actually you can then start to overlay some artificial intelligence on that. Now, I did have a video of how this worked, but Neil has let me down, and I will break his legs later. But what this was going to show you was a little video of about the 90 seconds it takes for our intensivists to access this app. And in that 90 seconds, the intensivist brings up a list of the intensive care unit, Joe blogs, Jane blogs, Derek blogs. Into that is then populated all of Joe blogs' biochem, hematology, previous micro, age, comorbidities, radiological results. Overlaid onto that is the previous units of the hospital that Joe blogs has moved through in order to get to critical care. Because if Joe blogs had just come ED, AAU, ICU, then Joe blogs' risk of having resistant bugs is going to be very different to the Derek blogs who cycled through medicine unit, oncology unit, hematological transport, and then into ICU. So it takes all that into account. Using a previous database of 160,000 patients that we've accumulated, it then looks for comparative cases for Joe blogs that have been through the same kind of units with the same comorbidities, with the same kind of biochem, same kind of radiological findings, same kind of FiO2 requirements now sitting on ICU, where they're tubed, not tubed, filtered, not filtered. And then from that smaller cohort, it then says, okay, so these punters were previously prescribed penicillin V and they all died. These punters were prescribed tazocin and they survived. And these punters were prescribed meropenem, amikacin, and linezolid, and they also survived. So you can then make your choice. Well, I'm probably not going to use penicillin V, but if all else is equal, then tazocin is not inferior to meropenem, amikacin, and linezolid. So, well, I'm just going to make that social choice and go for the narrow spectrum. And it doesn't replace the doctoring decision, it augments the doctoring decision. Shame that video can't work, but as I said, kill Neil later. So the next step then, right, so that's choice, right? Choice. But then it goes, how do we dose? How do we dose? Now I am basically superglued to either Pegger or Stephen, my two pharmacists, as we go round the hospital every afternoon, on a 4-hour ward round every afternoon. And they advise me in a very detailed fashion about dosing. And we all know the evidence base now towards beta-lactams being continuously infused, or at least having extended infusions. And that evidence base is there for carbapenems, for tazocin, for ceftazidime, at least for respiratory tract infections. Now, what our next stage is to build into our artificial intelligence that kind of dosing advice. But really what we're moving towards is personalizing that down to this Joe Bloggs type character. So we now have systems that are about postage stamp size that fit onto your antecubital fossa, and through continuous monitoring, go back and measuring the amount of beta-lactam in the interstitial space, tell you what your beta-lactam concentration is in the interstitial space, which is not that helpful. But knowing what we know about PK/PD, you then relate that back to the intravascular concentrations, or relate that back to the ELF concentrations, and then suddenly then you can start to develop dosing strategies for 150 kilo people versus 45 kilo old ladies. So this is where we're starting to go. Lovely. So that's choice and dose, right? But how else can decision support systems help you? Well, they can perhaps help you with effective IV to oral switch. Perhaps not these things, because as Phil said, they're rather unmalleable. But actually, when we know the criteria, we know when we should be stepping down from IV to oral, and that is extraordinarily evidence-based. What the decision support systems do can perhaps help us do that and enact that. And we can do that for bacteremic patients, and indeed there is evidence recently come out of the US that they can reduce time on intravenous antimicrobials for bacteremic patients there. But what stands in the way of that? Well, if you look at this work that's 5 years old now, that went out and surveyed clinicians, so not infectionists, clinicians from across Europe, including the UK, they said, what stops you from doing an IV to oral switch? Now, there are definite patient characteristics there that stop you stepping down. Ongoing fever, ongoing CRP. That's a different conversation. We can talk about that later. And I would argue then that probably involves a conversation with an infection specialist. But look up at the top there. So the big ticket items, so 20% of people said they didn't step down because it was the opinion of their supervising clinician, and 20% of people didn't step down because they forgot. And if you overlay onto that the kind of organisational factors, then another 20% of people didn't step down because it was the weekend. So actually there are a lot of very obvious barriers to IV to oral switch that perhaps decision support systems can cope with. Not all decision support systems in this realm have to be electronic. And indeed we have the rather nice mnemonic of home, which we have tried to engage across the board at our organisations to get people out of hospital faster. And it's mainly targeting our care of the elderly patients, where we need to keep them hydrated, we need to get them up and out and feeling like normal people and engaged with communities and out. But actually if you hijack this funky mnemonic as an infection specialist and say, well, actually we need to help your getting home. If you are hemodynamically stable, you can have things by mouth, all your numbers are improving, and you've not got a deep-seated infection. And even, I think John's going to talk about deep-seated infection, getting people out on orals later. But this is a very simple thing, and we have given this out to all our nursing staff. And I think, Mike, you were mentioning earlier about engaging patients with this. Yes, very much engaging patients. Yes, very much engaging medical teams. But actually, the nursing teams are an kind of a resource which we haven't yet leveraged yet, and it's the nursing teams who have to administer this and sink all their time into it. So if we can leverage nursing teams into helping prod doctors to make IV to oral switch appropriately, then really we'll be on a winner. But of course we do everything electronically that we do in paper, because that's just what we do. And we have in our bespoke app, which again, I've not yet found a way to do it in RX guidelines or microguide, we have an IV to oral switch pathway within there, which brings up the 7, and as soon as they click that, that goes into the electronic record, in that at least they have thought about an IV to oral switch for that patient that day. Whether they then do it is the next step. Short courses we heard a little bit about just now. So Martin's work as part of the initial workup towards the ARC project also not just surveyed these 100-odd trusts to look for variation in prescribing policy choice for common conditions, it also surveyed variations in duration for common conditions. And again, look at that variation. So we have the big black areas where nobody makes any recommendations at all, and then we have the kind of green and orange where perhaps we all should be heading. And we've seen this slide already, so Brad Spellberg from the US loves updating this slide every year, and it's a free publication for Brad as far as I can see. As more and more data comes out, he makes his table bigger and bigger, supporting the evidence between short course being equal to, so non-inferior to long course, helping his American colleagues and the rest of us who read these American journals be confident in our decisions to make shorter courses. And it's true for community-acquired pneumonia, whereas 3 days is equal to 8 days, albeit in children. Where treatment for pyelonephritis, 7 days is equal to 14 days, albeit for quinolones, not penicillins. Where 5 days is equal to 10 days for cellulitis, albeit for the very, very expensive Tedezolid. And where 4 days of therapy post-abdominal surgical explosion and then some surgeon fixing it, 4 days is equivalent to 8 days or more. So all that data exists, but all that data, as I kind of tongue-in-cheekly was trying to get across, does have very big caveats. So if you are trying to do short course therapy, make sure that you are doing it for the patient cohort for whom these trials were based. But what about decision support for short courses? So we have apps for our clinicians, as I said, but we also, and this is where our kind of thousands and thousands of pounds of expenditure goes, we also paid for ICNet, and I have no pecuniary interest in this organisation, but we pay about 30 grand a year for this thing. And you can think in your own mind what 30 grand is worth and how much manpower, person power 30 grand would buy you per annum, but we think that this is a good use. So what this system does is to every morning bring up all of the restricted antimicrobials. We get to preset the restricted antimicrobials, TAZ, Keftaz, Mero, Linezolid, they're all on there. It brings up all of the bacteremias, it brings up all of the ESBLs and new CROs from the overnight runs, and then it also looks for bug-drug mismatches down to the very simple level of little old lady on Augmentin for a urinary tract infection. Problem number 1, but problem number 2 is she then grows an augmentin resistant bug. It will flash that up in front of us. And that lets us coordinate our 3 or 4 hour ward rounds every afternoon to go and see these people and make interventions. And our ward rounds are facilitated by this and are kind of manifested by a pharmacist with one of us consultants walking around seeing these people every day. And we usually see about 30 people every day. And it allows us to have a breadth of impact across our hospitals, not just stopping, not just stepping down, but also stepping up, optimizing doses, looking for interactions and helping get people onto the OPAT pathway and upregulate our ambulatory care system. And then the last thing we've just been looking at just for the last 2 minutes is diagnosing infection. So that's why we're paid the big bucks or the little bucks or no bucks or whatever we're paid, is to try and cope with uncertainty and diagnose in an incomplete jigsaw what is going on with that patient. And how do we do that? We do that based upon our experience and our knowledge and chatting to other people, a lot of chatting to other people, and looking at some test results that come in. And a lot of test results do come in, right? So I just want to recount this slide, which I think Cordo has shown you a lot of data about procalcitonin this morning. There are lots of studies out there, as Cordo mentioned. So procalcitonin is just to orientate you to receiver operating curves for those of you not in the zone of ROCs. So basically they plot a best guess, which is the diagonal line, and then your test, which is the curved line. And the further the curved line is towards the top left-hand corner, the better that test is. So Cordo and I'm sure, would come to fisticuffs about some of these procalcitonin data where it's not so good for diagnosing pneumonia, it's not so good for diagnosing UTIs, it's okay at diagnosing any infection, but it's really the best for diagnosing bacteremia. Okay. Now you can quantify the extent to which this test is a good test, the extent to which that curve is to the top left-hand corner, by clocking the area under the curve. And you'll see there for the best thing for procalcitonin, you've got an area under the curve of 0.78 in this study. 0.78, remember that number. So we've got our system, which is Epic Import, which is funded by NIHR, as an ongoing study, and that's my hairy arms there, I do apologise, to look at routinely collected data, the kind of routinely collected data that you will have pouring in about every single patient coming into your take. And this was from that 160,000 patient data pool that we had all of their biochem, heme, micro, radiology, demographics, all in our electronic database. And then we said, okay, there's a lot of data there. Can we take the patients who had a positive microbiological sample that fits with infection? And we don't know, we couldn't be bothered to wade through 160,000 patients' notes, but you could tell that if a urine was less than 50 white cells and less than 10,000, we discarded that. So I'm talking about real samples that we as clinicians using we as infectionists using some rules could decide was infection. And then we took all of the other parameters that we had access to, biochem, heme, and we said which of those parameters best identify those who are likely to have positive cultures from those who are likely to have no positive microbiology in the duration of their stay. And so if you start with just white cell count, that's the blue line there. If you take white cell count in isolation, it's not great, right? If you add on white cell count as CRP, that's the pink line there, you're now starting to get an area under the curve of 0.69. And what was Cordo's procalcitonin? 0.79, right? Getting there. If you start to add in dyscrasias to some of the weird other biochemical things that you would not have innately thought were related to infection, right? So creatinine, bilirubin, ALT, ALP. If you put that as a composite, dyscrasias in these parameters suggest likely positivity of microbiology further down the line, then actually you get up there with an ROC curve of 0.83, which is now analogous to Cordo's 10 pounds procalcitonin, but for the cost of your standard biochemistry. So how does that perform, right? Because that was our validation piece of work, published in a journal I'd never heard of before, but they take kind of mathematical things with big equations and equal signs. Who knew? If you take that and then you roll it out prospectively to 100 odd patients coming in through the door, and you have someone who is sworn to be blinded, and they follow through the patient exactly, and using your preset power graphs about what is defined as a true infection. So none of this just they had some positive microbiology, because, well, that was just our validation thing, right? But these are true people with microbiology, with infections. Then actually, now look at our area under the curve is up to 0.84. So actually, we've now developed this system and we're taking it forward to try and use it to predict who is going to get an infection. Now, I love Gavin's talk, not least because he cited me. But Gavin also talked about shared decision making. And that paper that we did that Gavin mentioned really was looking at the impact of us getting it wrong in secondary care when it comes to talking to patients about infections. And one of the main things we found is when we get it wrong, we as a kind of corporate we get it wrong, we say, oh, you're going to get better from this, and then they spend 3 weeks in hospital. Or we say, yeah, you're going to need 4 weeks of antibiotics, and then one of our colleagues comes in 3 days later and says, no, tablets for you, home, bye. Or comes in and says, no, nothing for you, home, bye. That breeds distrust amongst our citizens for future infection encounters. So they, depending on which way we get it wrong, they're either more likely to take antibiotics in the future for inane causes, or less likely to take antibiotics in the future for really valid reasons when they need to take antibiotics. So actually we've overcome that using our decision support systems by having printouts for our patients, quantify, going through some basics. We think you've got chest infection, lovely. We think we know the bacteria because we grew it or we didn't grow it or whatever, but actually quantifying that uncertainty. Now we think the probability of you having an infection is 75%, 3 out of 4. So we're going to get it wrong 1 in 4 times. And we think that the most likely place that you're having this infection is your chest, but we're not totally sure. Now we have rolled this out, we've shown it to lots of patients, and their biggest thing was, this is lovely, but are you going to give this to me as a piece of paper because I don't have emails on my phone? And that's really because the majority of patients we have with infections are in the over 65 population. So quite the graphical user interface behind this and how we get it to our patients is ongoing, but that's kind of the last output from our computerized decision support systems. So they are useful to optimize empiric therapy and dosing. They are useful to support IV to oral switch and to enable all clinicians to aim towards shorter courses with those caveats. And they may be useful to diagnose infection-ish, but really what would be optimal is if we could diagnose no infection and stop all antibiotics. But that's going to get me my next funding grant. So I obviously work as part of a massive team, and in particular Alison Holmes and Tim Rawson, who are the powerhouses behind this. But thank you all very much for listening.